Hello, and welcome to Multidisciplinary Approach to Eosinophilic Esophagitis Management in Children and Adults. My name is Richard, and I'll be in the background answering any WebEx technical questions. If you experience technical difficulty at any time during this WebEx event, please submit your technical issue in the Q&A panel, and I will assist you. And please note that as an attendee, you are part of a larger audience today. However, due to privacy concerns, the attendee list is not displayed. All attendees will be in a listen-only mode for the duration of today's call. As a reminder, this call is being recorded. We will be holding a Q&A session during today's presentation, and you may ask a question at any time throughout the event by entering it into the Q&A panel at the lower right of your screen. I would like to introduce you to your first speaker for today, Kendra Valle. Kendra, you have the floor.
Hi, everyone. I'm Kendra Valle, Medical Advisor with Nutricia North America. I hope everyone is doing well and in good health during this time. And I want to thank you all for joining us for our webinar, Multidisciplinary Approach to Eosinophilic Esophagitis, or EoE, Management in Children and Adults. I'm very excited to introduce our speaker for today's webinar, Dr. Jonathan Markowitz. Dr. Markowitz is a pediatric gastroenterologist at Prisma House Children's Hospital and Vice Chair for Academic Affairs in the Department of Pediatrics at the University of South Carolina School of Medicine in Greenville. He has a long-standing interest in EoE and oversees their Center for Eosinophilic Disorders, which serves as a referral center for pediatric patients with EoE from across the southeastern U.S. His clinical and research focuses include dietary management for EoE, as well as some of the newer biologic therapies. Before I pass things over to Dr. Markowitz to start today's presentation, I have just a few quick housekeeping messages. During the webinar, you will see a few interactive polling questions pop up on the right side of your screen. Please enter your answer, and Dr. Markowitz will discuss the results once they are available. At the close of the webinar, we will be hosting a Q&A session. We received some questions prior to the presentation, which will be addressed. However, if you have any questions during the presentation, please type them into the Q&A box on the right side of your screen. Also, a copy of the presentation, as well as a recording of today's webinar, will be available for download on the Nutrition Learning Center within 2 to 3 weeks following today's event. And with that, I'm going to pass it off to Dr. Markowitz to begin today's webinar.
Hi, everyone. Thank you so much for taking time out of your busy schedule to join us this afternoon to talk about EoE management in children and adults. We'll jump right in so that we have a chance to get everybody back to their other regularly scheduled things. Start with just disclosures. And we were going to go ahead and start off with just a polling question. We'll do a couple polling questions of the audience interspersed throughout this, but just to get a sense of who's out there in the audience and who we're talking to. So we'll give about 10 seconds from the time the polls come up, and you guys can get those answers in. And then we'll kind of go over briefly once the results are in who we are speaking to today. So to get started, I'd like to just talk about a case, and this is a real case that presented to my office not too long ago. They were referred from their pediatrician. It's a 12-year-old boy, and came in with a chief complaint of dysphagia. The dysphagia was, in addition to a long-standing history of reflux, the reflux really dated back to infancy, but for the last year, he'd really been complaining of episodes of trouble swallowing, feeling that food's getting stuck, and those episodes were becoming more and more frequent and also more severe to the point where he'd had some impactions that he needed to cough back up, could never get them to go down. In addition to the dysphagia, he had reflux symptoms, the typical reflux symptoms that a 12-year-old might complain of, including regurgitation, heartburn. He also complained of abdominal pain. He had been on ranitidine in the past up until the recent FDA recall, but even when he was on the ranitidine previously, he didn't have any significant improvement in symptoms. But by the time he came to see me, he'd already been off of ranitidine for a month or two. And then, of course, the kicker is talking to mom, and she says, oh, and by the way, I have EoE, and I have asthma. So, when you hear a story like that, especially when you have a parent telling you that they have EoE as well, that, of course, is the first thing that my mind goes to. But in cases like this, even if it's not quite such a clear-cut case of EoE up front, whenever I'm considering EoE in a patient or whether that becomes part of my differential, I'm not just thinking about what the next step is, but I'm also even starting to think about where I'm going to go after that if they really do have EoE. And that's kind of what we're going to talk about a little bit more today. So quickly, just looking at our poll results, in case you guys can't see them, it looks like we have a lot of registered dietitians in the audience today. We have a registered nurse. We have a few MDs, PAs, nurse practitioners, and a few others as well. So it's great, a nice broad distribution of different types of practitioners out there. With regard to that case and with regard to our objectives today, I really want to focus on understanding the symptoms of EoE and how those might change in presentation based on the age of the patient, talk about the management options for EoE, and really go in more depth about a dietary approach of management for EoE, and also just talk about the importance of a multidisciplinary approach, collaboration between different specialists. So as I mentioned, I'm usually thinking about these patients a little bit in advance once I have an idea that might be what we're dealing with. And the first thing I'm really concentrating on is trying to get the patient to feel better. But at the same time, I want them to feel better, but I also remember how important it is that the disease goes into a histologic remission as well. And the importance of that is because the histologic remission is what really prevents the long-term complications down the road. And in particular, that's things like esophageal remodeling, laying down of fibrous tissue leading to strictures and scarring that might require dilatation. Those are the things that tend to lead to food impactions and significant dysphagia over the long term. So, I'm trying to keep in the back of my mind, like, yes, I want them to feel better, but yes, I also need to try to do what I can to prevent those long-term complications. And at the same time, try to have that patient have as good a quality of life as possible. And sometimes working extra hard to prevent complications is even a little bit at odds of maintaining good quality of life, because sometimes in order to do that, you are committing them to either medications that might interfere with their quality of life or diet restrictions that might interfere with their quality of life. And so there's always a little bit of a balancing act that needs to be done to get them where they need to go. And especially in the patients where dietary elimination is a part of the treatment, it's really important to keep in mind the need to pay attention to their nutritional status as well and make sure they're getting adequate nutrition. So this patient, as we mentioned, is a 12-year-old. He's kind of in that preteen, early adolescent phase, and he had symptoms that are pretty characteristic of early adolescents that present with EoE, and that's dysphagia, some food impaction, really a predominance of esophageal symptoms. But he also had some chest pain, some reflux symptoms, which are also very common in this age group, but especially common in some of the younger children as well. If he were even younger than that, he might be presenting with just vomiting, or if he were an infant or toddler, he wouldn't necessarily be able to verbalize symptoms like I'm regurgitating or I'm having heartburn or I'm having abdominal pain, but you might just see either the spitting, or you might even just see nothing more than feeding refusal, which might lead to some nutritional problems and failure to thrive. And so really, the older the patient is, the more esophageal predominant the symptoms tend to be. And that is most likely because the older patients probably have a longer duration of disease, leading to some of those symptoms of esophageal dysfunction and even fibrosis and stricturing. And the younger patients tend to have a little bit more of a nonspecific presentation, which might make it a little bit harder to get to that diagnosis as quickly. So here's a nice slide that summarizes the options initially for management. And so when I have a patient and I do confirm the diagnosis, I'm having a conversation with the family about where do we go from here. And there are really two main branches that you can go. You can go the route of pharmacologic management, which usually involves a proton pump inhibitor and often also involves a swallowed form of a steroid. Or you can go with dietary management, which involves restricting the diet in some way of foods that we suspect are the triggers for the inflammation. And you can do that by picking the most common food antigens, the most likely food antigens, and that's what we call empiric elimination, and that can be anywhere from 1 food to 8 foods. You could also send a patient for allergy testing and see what allergy test results come up and then target those foods up front. You could do a combination of elimination of food and putting them on some formula supplementation, or you can kind of go full bore and take them off all foods and put them on a fully elemental diet, which is based on an amino acid-based formula. It is hypoallergenic. It is very, very highly likely to induce a remission, but it also is a pretty life-altering approach. So we're going to kind of run through all of these different approaches now going forward. And the first one I want to talk about is proton pump inhibitors, or PPIs, for treatment of EoE. And PPIs these days are really a very common treatment approach to be used either alone or in combination in patients with EoE. I essentially try to get all of my EoE patients to go through a PPI trial at some point along the way. And there are different ways to approach that. The way that I prefer is what I have on here as option A, which is if I suspect they might have EoE, or even if I'm not entirely sure, but they have reflux symptoms that could be related to EoE, up front, I am usually treating them with a PPI before I'm committing to an endoscopy or any additional testing. If they get better, then I don't necessarily even get to the point where I need to do an EGD, and I really manage them symptomatically as long as they are doing well. The downside to that approach is that if they get completely better, they might have had a form of EoE that is PPI responsive. I really wouldn't know that for certain, but in my experience, those issues tend to kind of come out in the wash, so to speak, in that I'm not going to treat a patient, especially a pediatric patient, with a PPI forever without ever getting to a point of endoscopy. Even if they do well over a sustained period of time, I'm going to give them an opportunity to try to wean off that PPI at some point. And if they're unable to wean off the PPI, that usually is going to prompt me to do an endoscopy. And so usually we capture those patients eventually. If the symptoms don't get better when I put a patient like that on a PPI, that's when I am scheduling an endoscopy. That they have what looks like EoE at that point, we know it's not a PPI responsive form of EoE, and then we move on to different treatments. Now, other people take a different approach, and when a patient comes in their office that they suspect may have EoE, or maybe just has bed reflux and they're not even sure that they have EoE, they will do the endoscopy up front. And in those cases, usually if the biopsies and the endoscopy is consistent with EoE, then those patients typically get a trial of a high-dose PPI for about 8 weeks, and then a repeat endoscopy to see whether the PPI alone was adequate to treat the disease. And if it is, great, then you really only need to continue the PPI as treatment. If the biopsies or the visual appearance does not improve on the PPI, then you know it's not the PPI responsive form, and then you move on to other treatments as well. If they do respond to a PPI, they don't necessarily need any other treatment, although the EoE may very well respond to other treatments also. So it's up to the family whether they want to just continue treating with the PPI alone and move on to something different. So that something different pharmacologically is usually topical steroids. And when I say topical, I mean steroids that you swallow that adhere to the lining of the esophagus without really much systemic absorption. And there's 2 main delivery methods for those type of steroids. There's the meter dose inhaler, which are the steroids. Usually fluticasone is the most common one used, but mometasone, cyclosinide also have been used for EoE, and they take some puffs from those inhalers, but they're instructed not to inhale it, but just to puff it and then swallow it. The alternative would be taking budesonide, which comes in a liquid form, which was really developed for administration through a nebulizer. But instead of mixing it into a nebulizer and having them inhale it, we mix it into a slurry with something to kind of thicken it up. And the things that have been used most commonly are Splenda, the artificial sweetener, Nutra, which is a hypoallergenic type of cereal, or something viscous like honey or maple syrup, or some people use a sugar-free chocolate syrup that doesn't really have much real chocolate or anything else in it, but something that makes it viscous so that it'll adhere to the esophageal mucosa long enough to exert its effects. And the nice thing about the steroid approach is that it's relatively easy to administer, and you can find a form that usually you can get any child to take, whether it's the puff and swallow or the liquid. And there really does tend to be minimal systemic absorption with those. So side effects tend to be fairly limited. But the disadvantages of doing that are the potential cost, depending on what the copay may be for a family, how much out-of-pocket expense they have, and the fact that this is going to end up being a long-term treatment, because the disease relapses when it's discontinued. So you can put somebody on steroid, but you're basically making a long-term commitment unless you're going to make some other alteration in their diet that they're going to stay on the steroid. Otherwise, the disease is going to come back. And then there is some potential for side effects. About 20% in reports develop some overgrowth of candida in their esophagus. It doesn't necessarily cause an esophagitis or an irritation, but at least a colonization or an overgrowth there. And that's about 20% of the time. And then there are concerns about, does it have effects on growth or even adrenal function over the long term? And those haven't been hashed out as clearly, but they are things to be cognizant of in patients who are on these medications long term. Now, which one works better, the puff and swallow of steroid or the slurry steroid? Well, trying to get to the heart of that, Evan Dellin up in Chapel Hill did a study almost 10 years ago where he radio-labeled those two preparations of steroids, and then he looked to see where they actually went. And what he found was that the slurry seems to be delivered more consistently to the esophagus and the GI tract, as opposed to the meter dose inhaler, which is on the right, which, as you can see, got to the esophagus to a degree, but also did show up in the lungs, even though we were not asking those patients to inhale the steroid. And so based on this study, you would maybe conclude that the budesonide, the slurry, is likely to be more effective. But in the real world and in head-to-head trials, the effectiveness of them seems to be pretty comparable. So even though maybe the concentration isn't quite as high as in the esophagus with the meter dose inhaler, it does seem to be enough to be effective. Speaking of effectiveness, the actual effectiveness of the slurry preparation was evaluated in kids a number of years ago and showed that there was really a dose-dependent response. So lower doses didn't tend to be as effective in terms of inducing remission or really in symptoms, but using a combination score where they looked at the combination of symptoms and histologic response, what they found is that the medium and the high doses of the steroid tended to be the most effective, but even at best, we're only hitting somewhere around 50% effectiveness when looking at the combination of histology and response. If you look at histology alone, the high dose was the most effective and did have almost 100% response rate. So when I am using steroids, I am using something between the mid and high dose range that they recommended, and that's usually somewhere between 2 milligrams a day and 4 milligrams a day of the steroid, and that's budesonide specifically. Now, dietary elimination is the alternative way to approach these patients, and it happens to be my favored approach for a number of reasons that we'll get to later. As I mentioned, there are different ways to eliminate foods from the diet for EoE, and the empiric approach means selecting the most likely antigenic triggers. And you can do any number of those foods. The most traditional approach, and the first approach that was really published, was the Six Food Elimination Diet, and that eliminates the top allergens in the United States: cow's milk, soy, egg, wheat. Peanuts and tree nuts were lumped together. Fish and shellfish were lumped together to give us 6, although you can make the argument it's really 8 foods if you don't lump those two groups together. Subsequently, people have looked at doing a little bit less restrictions 4-food elimination diet usually refers to a combination of milk, soy, egg, and wheat. 2-food, milk and wheat. And so there are different ways that you can do it, although the effectiveness of that approach may vary depending on the number of foods that you eliminate up front, and the more restricted diets tend to be a little bit more effective up front. We can also use allergy testing to direct our targets for removal, but that does require a specialized type of allergy testing that we'll talk about a little bit later to get full accuracy and good effectiveness. And then there's the elemental diet I mentioned, where you remove all foods and just use the amino acid-based formula, which is far and away the most effective of the published approaches, but it also is the most life-altering. So empirical elimination, it works, and this study back from 2006 was really the seminal study to look at that 6-food elimination diet. And about 3/4 of the kids who were put on that elimination diet had a histologic response. And as you can see in the figure on the top right over there, there was also a really dramatic reduction in the average eosinophils, or the peak number of eosinophils in the esophagus in the average patient down before and after treatment for 6 weeks. So from an average of 80 down to 13 EOs before and after treatment. And this diet also happens to work in adults. It took a number of years, but an adult colleague of the person who did that initial trial actually replicated that study in adults and found almost the same type of results. Again, almost 3/4 had a histologic response, a very, very high symptom response, and symptoms recurred when the patients went off the diet. And on the figure on the left, you can see a very similar reduction in eosinophil count from before diet to after diet, and then you can see those numbers went right back up when the diet was when the diet restrictions were stopped. And so again, showed that the diet really did work, but that if you don't stick with those restrictions, you end up back where you started. And then there are the less restrictive diets, the 4-food elimination, and even a 1-food, just a cow's milk elimination. And what you can see there is that the response rates weren't quite as good. Also, it's important when reviewing some of these studies to kind of look at what threshold they used as their definition of response. And so in this 4-food elimination on the top, you can see that they used a response rate based on less than 15 EOs, whereas the original 6-food elimination diet used a response rate of less than 10 EOs. So they had a little bit less of a response, and they also used a less stringent measure of response, which just gets at the heart of the issue, which is eliminating less foods probably not as likely to give you as good a response up front than if you are casting a broader net initially. And then there's the allergy test directed approach. It's an approach that I happen to like because I'm fortunate in that I have some allergists who work closely with me and are willing to do that additional testing when needed. It's based on identifying the antigens through a combination of both IgE and non-IgE mediated allergies. And in order to assess those type of allergies, you need different types of testing. Skin prick testing, the kind of traditional skin testing we think of for food allergies, will identify IgE-mediated allergies. You can also identify those by using RAST testing, a blood test. But looking for non-IgE-mediated allergies requires a test called an A to B patch test, where a portion of whatever food you're testing, a pure version of that, is placed on the skin under a patch. It's taped down in place, and it's left there for 48 hours. Then you remove the patch, you wait another 24 hours, and you look and see whether there's been a skin reaction that usually is kind of a erythema, redness, plus some induration there. And the problem with that type of testing is that not every allergist feels real comfortable doing it. Not every allergist has a lot of experience doing it. And there's also some subjectivity to interpreting the results. So if you have somebody who's not as used to reading those tests, you may not get as accurate a result. But when you have an allergist who does that type of testing and you use the combination of the prick testing and the patch testing, you can get results that are every bit as good as the empiric dietary elimination. And this is some data that we did a number of years ago based on our population, and what we found is that almost 60% of patients who had dietary elimination based on this approach got to a complete remission, like basically no EOs left. And then if you included those that had up to 15 EOs per high-powered field, we have a 69% response rate, which again is pretty close to the response rates published in these other studies. So if you have an allergist that's willing to do it with you, you can get a great result, and we'll talk about why that might be preferable if you can do it in a few slides. In terms of elimination diets in general, there are some drawbacks, and the biggest drawback is that it can be difficult to implement. To do it, the patients need to be instructed on how to read labels correctly, how to make sure that they're not getting any inadvertent exposures to the foods, no cross-contamination, and also it's important to make sure that they are still able to get adequate nutrition with eliminating what turns out often to be a lot of staples of the diet. So make sure they get enough proteins and calcium and vitamin D and other minerals if they're not able to take cow's milk and other protein-rich foods, which tend to be the ones we're eliminating. Also, it can be a difficult diet to maintain long-term. The process of identifying the foods can take a while. Yes, we take our best guess based on the empiric elimination or on targeted therapy, but that first go-round may not be effective, and then you have to make an adjustment. And when you make an adjustment, you have to go back and do a repeat endoscopy, and then you might have to adjust again. And so it's an iterative process that might take some time to get there. And then if you're on a really highly restricted diet over the long term, that can be tedious for the patient as well. And sticking with a diet where they can't have milk, wheat, soy, egg over the long term can be difficult because it doesn't leave as many of the things that we usually eat in the diet, and you have to be creative to make your diet, interesting and still taste good. The diets up front can be overly restrictive. They might not be restrictive enough. Again, we cast a broad net a lot of times in the beginning, but we may find that in the beginning we were restricting more foods than we had to. Likewise, sometimes we do that first round and it's not restrictive enough, and we have to continue to pull foods away. And then there is the risk of nutritional consequences anytime you're significantly altering the diet. So you want to monitor nutritional status closely. That's height, weight, BMI. It's really optimal if you have a dietitian who can help you to co-manage these patients and really help to stay on top of their nutritional status. And it's really not uncommon for patients who are on dietary elimination to need some supplementation to get those adequate calories and vitamins and minerals. And an amino acid-based formula is a great way to do that because it offers the nutrition in a hypoallergenic way. And then there's the elemental diet that I touched on previously, and that is exclusive feeding of an amino acid-based formula. It's 100% hypoallergenic, so as expected, you would have a very, very high response rate to that. And in pediatric trials that we did dating back almost 15 years ago or more, we showed up to 97% of patients responded to this diet when they did it, which far and away is the most effective option out there. But the disadvantages are that it is the most life-altering. It's not uncommon for patients to need a nasogastric tube or a surgical gastrostomy tube to be placed in order to get enough of the calories in. And then there is a potential for significant cost if the family is having to pay for the formula out of pocket, although fortunately there has been a move in recent years for state legislatures to mandate amino acid formula coverage for conditions like this, but it's variable from state to state and certainly from private insurance plan to private insurance plan. So it's something that needs to be considered before instituting a diet like this. I mentioned our trials in pediatrics that were really effective. Well, it turns out it's pretty effective in adults as well. And this trial from just a few years ago showed that a 94% response rate to the diet, 71% had a complete remission, and a much higher proportion had a complete symptom response. Every patient felt better, and almost all of them had a complete response in terms of their symptoms. They did tend to relapse fairly quickly when they came off the diet. And as you can see on the left, their eosinophil counts also dropped significantly. So the diet works very well in adults and children. The problem is getting adults to continue to do the diet, which that has been the biggest challenge for people who try to implement that. So the limitations, as we've already mentioned, it's life-altering. During that initial phase of the trial, really, we don't want them taking any other foods. We might allow some non-antigenic foods like very simple sugars or artificial flavors. So it does allow things like Kool-Aid or popsicles or things like that. Gatorade usually is okay, although we look for the things without any natural flavors. We really look for the artificial flavors, which seems, kind of counterintuitive when you're trying to get somebody to take a healthy diet, but the artificial flavors are less likely to cause problems in terms of allergies. Palatability of these formulas, it's really improved a lot over the years. When we first started using these formulas, they were really unflavored and they didn't taste good. There's now a lot of flavor options in these formulas, and they taste way, way better, but it's still usually a very large volume that we're talking about when somebody's on them exclusively. So to get somebody to take a 1.5, 2, 2.5, 3 liters of these formulas every day can be difficult. The formulas are designed to be nutritionally complete, which means if you get your full calorie estimate of it, you should also be getting your full micronutrient estimates, but it is important to just keep in mind that micronutrient deficiency still can occur. And so it's important to monitor height and weight and also consider monitoring lab work, iron studies, micronutrient levels, vitamin levels, things like that if somebody's on these long term. And it can take a while to get to the point where you don't need to rely on the formula to a large degree. So, we start the formula, we do it exclusively, we wait 4 or 6 weeks, we do a follow-up endoscopy. If we show that the patient is in remission at that point, we can start adding some foods in, but we're usually only adding 1 or 2 or maybe 3 foods most per trial. Then we're waiting another 4 or 6 weeks doing a follow-up endoscopy. If you pass it, well, that's great. You can keep those foods and add a few more. If you have a relapse, then you've got to pull those foods and you've got to start with new foods. And so the process of getting to a point where you really don't need the formula at all, or don't even need a significant amount of the formula, can take months or even a year or more. And so it's a long haul for people who want to go that route. So just summarizing and kind of going back and comparing the different treatment options. So steroids versus dietary management. The steroid approach is probably the easiest approach, and it does tend to have relatively few side effects, and you don't need to have a specialized allergist or any particular allergy testing to do it. But you do run the risk of not getting to a complete remission, and it is a long-term commitment. It's really an indefinite treatment course, and you have to keep in mind that if you decide you're going to come off the medicine, that the disease is likely to relapse. And it really, in my perspective, is kind of a Band-Aid approach. You're not getting at the underlying cause of the disease. You are just masking the inflammation that the reaction is going on. Now, the diet approach is a little bit more difficult, but it doesn't really tend to result in any side effects. Depending on which diet approach you're going to use, it might require allergy testing, but you're a little bit more likely to get to a complete remission. You don't need to be on medications, and it really does get at the root cause of the disease, which I think is beneficial in the long term. Comparing empiric versus directed therapy, the big difference is the need for allergy testing. The empiric approach, you don't need to have the allergy testing done, and there are multiple options, whether it's a 6-food, a 4-food, or a 1-food. Although the more restrictive you are up front, the more likely you are to get to remission earlier on. But no matter which of those options you use, you're removing some dietary staples, and that can be more difficult. The directed approach based on testing relies on the ability to get that testing done, and it's highly dependent upon the allergist and their comfort with the testing, but it may bypass elimination of some of those dietary staples, and the diet may not be as restrictive up front, but still get you to remission. So just out of curiosity, how are y'all approaching the initial management at your center? We'll just kind of see what people are doing out there. Go ahead and log in your answers. We'll give you a few seconds, and then we'll talk about the results as they pop up. And so it wouldn't surprise me if what we end up finding for results is that there's a variation. And we looked at a collaborative of centers in North and South Carolina that take care of patients with EoE, and we get together periodically to discuss our management approaches. And we did a study of who's doing what. And what we found is there was really wide variation among our centers. Some centers use steroids as their initial management approach about 86% of the time, and then other centers hardly ever used it. And then there was really the flip, where some centers use dietary management initially the vast majority of the time, and others hardly ever used it at all. But what we found was fairly consistent was that elemental diet was really not a typical initial management choice, and that's because it really does tend to be one of the more restrictive, hardest diets to do. And in my experience, the only patients I'm really doing elemental diet for my initial management are either infants who are pretty much exclusively fed formula anyway, and so you can make a switch to the amino acid based formula without too much difficulty, or patients who have a gastrostomy tube in place for other medical conditions already and are essentially formula fed most of the time. And so again, just makes an easy switch at that point. And sometimes those management choices are also driven by the resources available to the provider. So who's doing the primary management? If you have a gastroenterologist, an allergist, and a dietitian available, then doing dietary management becomes a little bit easier. If you don't have a dietitian available to you, or you're kind of doing things alone as a GI or as an allergist, you might pick medical management because you have the resources available. And then let's just look back at our poll question here. So it looks like, again, a pretty wide variation where about a quarter are doing pharmacologic management first. There's some people doing elimination diet first. Again, about that same percentage, up to 6% doing elemental diet with a lot of combination therapy and a lot of variation from patient to patient. So that's very similar and mirrors pretty much what we have been doing in our practices in North and South Carolina as well. So just getting back to our case, so my initial approach with this 12-year-old was to put them on a PPI and then kind of wait to see how they did over those first few weeks. And the plan was if he had, continuing symptoms, didn't have a significant improvement within that first 4 weeks, I'd go ahead and put him on the schedule for the endoscopy. That usually, with most of my patients, puts that initial endoscopy out at a 6 to 8 week mark. Whereas if the symptoms are not improving, if the symptoms are improving, I usually will continue to treat them for another few months and then reassess to see whether things got completely better or not. And if they get completely better, I might hold off on the endoscopy and just treat them with the PPI longer. But if they don't get to that complete resolution of symptoms, then I'm usually still moving forward with the endoscopy. The problem was that when I saw this patient, it was right before the pandemic really hit its peak, and as it did, there were limitations put on us in terms of being able to do elective procedures, and so everything kind of got put on hold. And so he's still been on the PPI. He's actually doing a little bit better, but the plan is to bring him back now that we're able to start doing procedures again. And so, with the pandemic, it did make me kind of go back and think about some of my approaches to these patients. And so if I had a patient that was getting diagnosed right before the pandemic, had their endoscopy, confirmed the disease right before the pandemic, I was going to be a little bit more likely to use steroids for them because at least it was a little bit more of a predictable response, and that I could do the steroids until we get through the pandemic when I can go back and start doing my procedures again and reassess things. And then, of course, we can always wean them off steroids and go back to diet if that's the approach that they wanted. I also was really starting to think about whether one of my highly symptomatic patients who I didn't get a chance to confirmed the diagnosis yet should start therapy even before I get to do the endoscopy. And of course, that's the least optimal situation. But somebody's having really frequent food impactions, who I really suspect has EoE. I was thinking about whether I would go ahead and just put them on steroid to get them through, and then wean them off. When we can go back and do endoscopy. Fortunately, I didn't run into that situation, but it was something I kind of had in my back pocket. And then the other change that I really made was to hold off on any management changes on any patients who were already established patients. But I didn't want to make a change when I didn't know when I would be able to go and reassess things. So we've been kind of holding off, and now just over the last 2 weeks, we've been allowed to start doing our elective procedures again. So now we're kind of getting back to our baseline. So one last polling question just to ask, what y'all have experienced out there in terms of how you've changed any management relating to the pandemic. And did you change your use of steroids? Did you avoid making any changes? Did you avoid doing food trials? How many people were unable to do elective procedures? The other thing that we really initiated a lot of was telehealth, where we went through a few weeks where we did almost 100% of our visits via telemedicine. Now we're back to kind of seeing patients in the office almost exclusively again. But there was a few weeks where it was literally almost 100% telemedicine visits. So I'd be curious to see what you all say. Just to wrap up over these last couple minutes, I just want to kind of go back through my proposed approach for initial management of these patients. And so the first thing I'm trying to do is confirm the diagnosis. And in most cases, I'm trying not to perform an endoscopy until the patient has been on an adequate trial of PPI. But in the cases where our hand is forced and we end up doing an endoscopy before they've had a PPI trial, I usually will then go ahead and start the PPI trial if it looks like they have EoE, and then end up doing a follow-up endoscopy after the PPI trial. So, and then just going back to our polling question real quick, looks like a lot of telehealth visits, which is like us, and discontinue of elective procedures, but it doesn't look like there's a huge impact on the other EoE management parts. Now, once we have a confirmed diagnosis and we're going to start managing these patients, if the patients really have severe symptoms like dysphagia or recurrent food impactions or weight loss, then those are the patients where I usually recommend a trial of topical steroids, even if I'm going to do dietary management, but just try to bridge the gap and get them into a remission a little bit more quickly. And if they have a stricture present, they may have gotten dilated at the time of the endoscopy, but I also will really consider putting them on oral prednisone to even more aggressively treat that inflammation up front with a plan of bridging to dietary therapy if they're willing to do it. Now, if their symptoms are pretty mild, I will not usually recommend steroids up front unless the family is really opposed to doing diet restrictions, and I'll make the referral to an allergist for testing. And in the meantime, I might even start them on an empiric restriction of milk and wheat, or depending on how far they're willing to go, I might do a 4 or 6 food elimination up front, waiting on the results of the allergy testing, and then kind of hone the diet based on the results of the allergy testing before we settle on the final plan. Working with that allergist will hopefully identify some foods to target. As I mentioned, the experience of the allergist is really important. False positives, false negatives do occur, and patients should be aware of that. And there's some subjectivity to reading those patch testing. I'm almost always eliminating cow's milk regardless of the results of the testing, because the testing for it is notoriously inaccurate. So we make the assumption that they're allergic to milk until proven otherwise, because milk is the most common trigger, and the allergy testing usually doesn't help us very much. I usually will arrange for a visit with my dietitian at that point so they can go over the nutritional needs of the patient and also instruct them on whatever dietary eliminations are needed, and also make the assessment whether they need formula supplementation. If the allergy testing turns out not to be helpful, then you can fall back to that empiric approach. Again, meet with a dietitian, assess the need for amino acid formula. Once they're on whatever dietary elimination we decide to start, that's the point where I discontinue the steroids if they were started, and then look to schedule an EGD about 6 to 8 weeks later. If they're in remission, great. You don't necessarily have to change anything, or you can offer the opportunity to reintroduce some of those foods. If they're not in remission, then you've got to make some additional adjustments or consider different treatments like elemental diet or steroids. Once we start a new approach, whenever we make a change, then there's a repeat endoscopy that needs to follow to make sure that the response was there and that the change you made was effective. Once they're in remission, then you're good. You don't have to change anything, but it does open the door for food introductions. So who should really be driving the ship, so to speak? Usually it comes down to either a gastroenterologist or an allergist. And it doesn't have to be either one or the other. And some of the factors that might determine who it is, it can be just as simple as ease of access. If the family lives closer to the GI and they have to travel 2 hours to see the allergist or vice versa, that might make one versus the other a better choice for the family because it's easier for them to get in. Of course, experience and expertise with the disease is important. And where are the other resources that they might be taking advantage of located? So if the dietitian works in the GI office, it might make more sense for the GI to be making the decisions. If the dietitian works with the allergist, it may make more sense for the allergist to be doing it. What other services are there? Psychologists, feeding specialists, are they all part of the health system of one specialist versus another? That might drive who decides or who takes the lead in making the decisions. But regardless, I think the most important thing is that a shared approach is important. And that means that the team really needs to have a shared philosophy about ways to manage this. If you have one specialist who's opposed to doing dietary therapy and only wants to do steroids, and the other doesn't like steroids and only wants to do dietary therapy, there's going to be too much push-pull, and what's likely to happen is the family's going to get a mixed message, and you're less likely to get a good outcome because they're going to not be doing whatever they're supposed to be doing to the full extent. And good communication between the specialists is really vital as well. They really have to speak the same language. When we talk about remission, they have to have the same idea of what remission is. When they talk about what's an adequate response, they have to have the same idea of what an adequate response is in order for the patient to get the right message. So here's a little table that I put together that kind of lists what I think are the key roles of the two main specialists, the GI and the allergy specialists. Of course, the gastroenterologist is the one who makes the definitive diagnosis by the endoscopy, and then they are certainly able to make management recommendations. They should be monitoring GI symptoms and managing any complications like strictures or food impactions. They can instruct on food reintroduction afterwards if you're doing dietary elimination, and then they'll be the ones who have to do the follow-up endoscopies to see whether there's been a histologic response. And then, as we know, a lot of these patients have other coexisting GI symptoms, whether it's reflux or abdominal pain, diarrhea, or constipation. You would expect the GI person to be involved in managing those. On the other hand, the allergist frequently is the specialist who identifies these patients. It's really not uncommon for the allergist to be seeing a patient in their office who has asthma or eczema or seasonal rhinitis, and the patient mentions to them that they're having trouble swallowing or they've really bad heartburn or they've been vomiting, and they make that a referral to the GI, and then we end up diagnosing the patient with EoE. The allergist, of course, does the food allergy testing and then can also make the management recommendations. Also, I frequently ask the allergist to retest for allergies after somebody's been on a prolonged elimination of a food. We're finding with increasing frequency that people who've been on long restrictions of foods before they reintroduce them have a little bit of a higher risk of having an anaphylactic type reaction. So if I have any concern over that, I'm asking the allergist to do some allergy testing to make sure that it's safe for the family to reintroduce the food before they do. The allergist can also instruct on food reintroduction and then can manage the coexisting atopic conditions that are also so common in these patients. But bottom line is, if there's not agreement between these two specialists, it's not an optimal situation to get a good response. I mentioned there are comorbidities that go with this disease, and so we mentioned the atopic issues, but psychologic issues, anxiety, depression, behavior problems, especially around feeding, are very common. And we're also finding that patients with EoE have increased frequencies of connective tissue disease and mitochondrial disease and dysautonomia. And so having a team approach really is very helpful. And so I look at the team of specialists as a pretty broad team, not just GI and allergy, but certainly a dietitian plays a huge role. Psychologists and feeding therapists play a huge role. If you can have a coordinator who can help coordinate the visits between the allergist and the GI and then the other specialists, and try to, especially for patients who have to come a long way, get them in so that they can see all these specialists in a short period of time or all on the same day. That's really helpful. If you're going to do industry-sponsored studies, you need a research nurse who can help maybe offer some of the newer trials that aren't quite available commercially yet. And then because they have so many other comorbidities, having a pain specialist, a rheumatologist, cardiologist can be so helpful, among other specialists. So with that, I think we will, I'm going to hand things back over to Kendra and certainly start fielding any questions that you all may have. I am going to move forward to one slide here, and this is just kind of a summary slide that covers almost everything that I talked about in one slide, and I know that one's going to be available on the website for anybody who wants to have it. And so I'm going to move to this last slide for Kendra and then just turn things on over to her.
Perfect. Thank you so much, Dr. Markowitz. That was very informative. So as Dr. Markowitz mentioned, we're going to get started with the Q&A session in just a minute. So if you have any questions, please type them in the Q&A box on the right side of your screen. The EoE management flowchart that Dr. Markowitz had just referenced is available on the Nutrition Learning Center at nutritialearningcenter.com and can be found on the GI Allergy Clinician Resources page. To receive CE credit for today's webinar, please complete the survey by visiting the link currently displayed on the screen. So you can take note of this URL, you can click in the hyperlink in the chat box, or you can wait for the survey to pop up immediately following the conclusion of the event. We really appreciate you completing the survey and truly value your feedback because this helps us continually improve our educational offerings. Upon completion of the survey, you will obtain the webinar code, which you can then enter into your NLC dashboard on the Nutrition Learning Center at nutritialearningcenter.com. And upon entering the webinar code, you will be able to view and download your certificate on your NLC dashboard. All right, so we're going to go ahead and get started with the Q&A session. We did receive a number of questions, Dr. Markowitz, with the first one being, how long does it take for the EOs or eosinophils to appear after eating a trigger food or foods?
So it's a great question that I don't know the definitive answer to, but I can tell you based on some of the studies that we did personally and some other studies that it's somewhere between probably 7 and 30 days that we start to see most of those reactions occur. When we did our initial study of an elemental diet in patients, we did our first follow-up endoscopy 30 days later, and after they would start reintroducing foods, and so we would usually find that those are where the eosinophils were starting to come back. But in the adult study, the elemental diet study, they actually took some of those patients and did a follow-up endoscopy 7 days after taking them off the elemental diet, and the patients had relapsed. A lot of the patients had relapsed within that first 7 days. It may vary a little bit between what foods you're taking back as well. So I've found that wheat in particular, I've had some patients where we've done follow-up endoscopies at even 6 or 8 weeks that are fine, but then the patients seem to subsequently have abnormal endoscopies that we could trace back to the wheat, but it took even a few months. So it is variable, probably from patient to patient to a degree and from food to food to a degree, but at least in some studies, we're seeing that within 7 days, there's evidence that the reaction is occurring.
Okay, thank you for that. Another question, have there been any studies that compare the effectiveness of a strict dairy elimination diet to a dairy elimination diet that allows foods with baked dairy?
So I'm not aware of a head-to-head trial between those two things, but I can tell you that when we have a patient who is milk allergic and they've been on a milk restriction, one of the ways that we will sometimes start milk introduction is by just allowing baked milk and not the full, kind of regular milk. So they're doing milk or cheese or ice cream, but just as an ingredient and something else that's baked. And we do have some patients who can tolerate the milk when it's baked alone, but not when it's in its more pure form. That really seems to be an individual thing, and it depends on the degree of sensitization of those patients.
Okay, thank you. In a patient with EoE, the elimination diet may cause macro and micronutrient deficiencies. As a result, what are your thoughts on recommending an amino acid-based formula at the beginning of management in combination with the elimination diet?
So, I mean, I think, again, it's a bit of an individual question based on how extensive their elimination diet is. And that's where, I will say I rely so strongly on my dietitian to help me in making those decisions. But if you are pulling, a large number of real staple foods, I mean, if you're doing a full 6 food elimination diet up front, those are the patients who are most likely to benefit from some supplementation of an amino acid-based formula, because those are the ones where you are just so drastically altering what is their usual intake of proteins and vitamins and micronutrients, that being on a supplemental formula and those really can be helpful.
Okay, thank you. Another question. By treating with PPIs first and not doing a scope, which is what we used to do for years, the issue is you never have a diagnosis if the patient improves. Are you concerned with missing an EoE diagnosis with this approach, given long-term risk of fibrosis and strictures?
So that's really at the heart of the issue of choosing whether to treat with PPIs first or not. And I will tell you, I am not really worried about it, because I think, as I mentioned earlier, I'm never treating forever with a PPI. I'm always going to bring that patient back and try to reassess whether they can come off of it. And so if I've had a patient who's had a great response, they're on a PPI for, let's say, a year, and they have no symptoms anymore, I am going to try to wean them off of that PPI. And if they continue to fail weaning of the PPI, they're going to get their endoscopy. So I don't worry so much about it over the long term, and I just try to stay on top of those patients to the point where it kind of works itself out one way or the other. But if that is a big concern of yours, then it is perfectly reasonable to do the kind of option B that we put out there and scope them first. I just always felt like I hate to put somebody through 2 scopes to make 1 diagnosis. And so that's been the approach I've used. And I haven't had anybody who has shown up with a stricture because I had them on a PPI for a year before we diagnosed their EoE. Unfortunately, that hasn't been something I've run into.
Okay, thank you. Another, do you have any concerns about using pea-based beverages with the 6 food elimination diet?
So I don't have any overt concerns over that, other than, the peas and soy are both legumes. And so people who are legume sensitive might have some issues with peas, or if they're soy sensitive, there may be some cross-reaction with peas. But again, that's why these diets don't always work 100% up front, and you just have to make adjustments if they don't. So if you had somebody who's taking, the Ripple milk, the pea protein milk, or some of the pea protein cheeses or things during their initial phase of dietary therapy, and you don't get them into remission, then that might be the next change, is to try to take them off that and see if that was the remaining antigen that was continuing to contribute to the ongoing inflammation.
Okay, thank you. I realize we have 1 minute until the top of the hour, so I'm going to squeeze in just one more question, if that's okay. Can you talk a little bit more about food reintroduction, and what is the protocol your office follows for reintroducing trigger foods?
So I guess you could answer that a couple different ways. I mean, so in a general sense, our approach is that we try to do a limited number of foods per food trial, and depending on how antigenic the food is, we might only do it as a single food. So if we're doing a trial of milk or wheat or one of the real big staples, but also big antigens, I might just do that food alone. I usually wait 6 or 8 weeks on the food and then do the follow-up endoscopy. But that's assuming they don't have symptoms. And it's not uncommon for us to start a food trial with the food and they start having worse reflux, or they start vomiting, or they have diarrhea, or they have some symptom that clearly starts, after the new food. And if that's the case, we usually ask them to stop the food and see if the symptoms go away. And if the symptoms go away, I consider that a failed food trial. I don't necessarily do an endoscopy. I just let things kind of wash out, and then I move on to the next food. So if that's what they mean by kind of the protocol, that's kind of how we handle it. If they're doing kind of lower antigenic food, so if they're doing, a fruit or a vegetable, we might let them lump 2 or 3 or 4 together. Do it still sequentially, like do a new one, wait a week or 2, do a second one, wait another week or 2, get a third one in a week or 2, and then once they have the full number of foods we're going to do in their diet, then wait another 4 to 6 weeks to do the endoscopy. But we always tell the family that when you're doing lumped food trials, that if the follow-up endoscopy is abnormal, we're not going to know which food caused it, and that you kind of lose all 3 foods, or at least you have to then sequentially remove foods and go back and retest afterwards. So that's the downside to lumped food trials. But of course, the upside is if you pass all 3 foods, you limited the number of endoscopies that you need, and you made more progress in a shorter period of time. So there's a balance there. But that's why, like, if it's something like milk or egg or wheat, usually I recommend just doing that as a single food trial because I want to know that answer definitively because it's such a key food. And so those are the ones where I just say, let's just do this and not test anything else that might muddy the picture.
Mm-hmm. Okay, thank you. That's very helpful. So we are out of time. Thank you again, Dr. Markowitz, for your presentation and sharing your insights on these questions. And thank you again to everyone for attending today's webinar. As a reminder, a copy of this presentation as well as the recording of today's webinar will be available at nutritialearningcenter.com within 2 to 3 weeks. To claim your certificate for today's webinar, please complete the survey, which will appear immediately following the conclusion of this event. Thanks again for joining us, and we hope you have a great rest of the day.
Thank you, everyone.